Hi, my name is Schabowski, and I'm really excited about doing this resuscitation didactic module for you. Resuscitation is by far my favorite part of emergency medicine, and I think over the years I've learned a lot of little tricks about how to manage patients and how to keep myself in control so I know what I'm doing and so I can take good care of the patients. I've kind of dummied this down into a few rules that I use myself on my patients, and hopefully I can teach them to you so you don't have to wait 10, 15 years of a career to get this understanding. Hopefully I can impart that on you now so you can go forward faster than I ever could have. So we're going to start this module with the introduction, which is the ABCs. You walk in a room and what do you see? A patient who looks like he's dying and you have no idea why. But it's up to you to figure it out and pull him out of the jaws of death. Are you scared? What are you afraid of? You're afraid that it'll be impossible and the patient will die and you won't know what to do. But it's totally possible. What you have to do is learn the rules of the game, and then you just have to play better than anyone else. What I'm going to show you today are some rules to live by. All right, let's start with the ABCs. I believe that the ABCs equal control. If you know and have assessed everything about the airway, breathing, and circulation, and you know what's going on there, you have control of the situation to some extent, and you can move from there. The patient is alive, you have time to think, it's awesome. So what it does is it brings the initial assessment, it brings everything into focus in chaos. If everything goes wrong in the middle of a resuscitation, it helps you to gain control when you face an unexpected twist or deterioration. You just do the ABCs again, you're back on your feet, you know what you're doing. If you control the ABCs, you buy yourself time to think about the details. All right, let's start with a rule. First rule of airway. All unconscious patients need to be intubated until proven otherwise. Your action in this case would be to check the gag reflex. Patients who are awake and upright and speaking in a normal voice have a clear airway. You've cleared the A, you can move on to the B. Breathing has two components, oxygenation and ventilation. Imagine this. What would happen if someone came up behind you right now and put a plastic bag over your head and tied it tight? How would you react? You would react the way someone in oxygen failure acts. They have manifestations of hypoxia, which when mild to moderate result in a patient who's frightened, tachycardic, tachypnic, and having an epinephrine surge. When it becomes severe, the patients become frantic and uncooperative, pulling off the mask, ripping off the IVs out, and trying to get off the cart. Patients who come in respiratory distress should be sitting in an optimal breathing position. If they're in severe respiratory distress, they should be doing everything they possibly can to breathe well. This is the best picture I could find on the internet. I think this kid probably has cystic fibrosis, but he shows a really nice example of the perfect breathing position. His head is up and in a sniffing position. His jaw is thrusted forward. His oral pharynx is wide open. His chest is extended. He's leaning forward to take the weight of the chest off of his lungs. He's supporting his chest with his arms and keeping himself upright. This doesn't show so much in a kid, but older people who have big bellies, if they sit forward and lean, what they do is they take the weight of that belly off their diaphragm as well. Oxygenation failure will be a profound, persistent hypoxia despite treatment and supplemental oxygen. We'll move now to ventilatory failure, the other component of the B. What happens here is you get accumulation of CO2, which overshadows the epinephrine surge and flight or fight response. You get CO2 narcosis. The body starts to relax while the respiratory threat continues. This is some of my best work here. This is a picture showing the transition to death when someone is in severe respiratory distress. They start out in that sniffing position. They clearly can't breathe. If they continue without being fixed, they'll start to lean back. They're getting tired. They're looking at you thinking, please notice, fix me, or at least intubate me. If they start to flop over to their side and start to become unconscious, clearly you need to call a code. The patient is looking into the light and is going to be dead soon. Hopefully you'll notice the transition in the middle before they get to the end. Resuscitation rule, no one should be relaxed when they can't breathe. It absolutely doesn't make sense. Remember these kind of things because the obvious is actually what saves you in resuscitation. If you acknowledge and recognize the obvious abnormalities of what's going on with the patient, you often catch the transition to a worse situation before it can go there, and then you're more likely to save your patient. This is what the rules are based on. All right, again, ventilatory failure. This is collapse of compensatory mechanisms. The oral pharynx becomes compromised, the AP compression occurs, and the chest wall weight is on the lungs. You get compromised expansion, diaphragmatic excursion can be reduced, especially by a big belly if the patient starts to flop over. They get rapid accumulation of CO2, progressive acidosis and cardiac compromise, worsening hypoxia, and a high risk of precipitous cardiopulmonary arrest. This is a picture just to show you that when patients have a high BMI, this transition occurs much more quickly. They have rapid deterioration and arrest quickly, especially if you wind up sedating them or compromising the airway by your interventions. The Detroit Medium reference comes from a friend of mine named Chris Lewandowski. He works at Henry Ford, he's the residency director there. And we were at, I think, SAM, and he said, I asked him, I'm like, are you guys having a lot of these people coming in that are like 300 plus pounds, 350, 400? I'm like, we seem to be seeing a lot more people like that. And he said, yeah, we call them a Detroit medium. That's where the reference came from. All right, one more time through ventilatory failure to remind you. Collapse of compensatory mechanisms occur. Rapid development of marked respiratory acidosis. Relative bradycardia, which quickly progresses to asystole, and full cardiopulmonary arrest. Here's a rule. Don't forget. No one in respiratory distress should be relaxed, fall asleep, or have a heart rate less than 100. There should be a clear epinephrine surge going on here. They should be having a flight or fight response. They should not be calming down and their heart rate going down. That is a very bad sign. These signs should raise the red flags of impending cardiopulmonary arrest. Spelled wrong, sorry. All right, let's look at it from a different perspective. You're going through the ABCs. How do you clear the B? Well, quickly, you can clear breathing as far as assessment of the ABCs by seeing a patient who's lying on the cart comfortably, calmly, and easily answering your questions. In this case, the B is cleared. You move on to C, circulation. All right, circulation has 4 components. 1, vital signs. 2, pulse and capillary refill. 3, mental status. And 4, cardiac rhythm. People often forget the cardiac rhythm as part of this assessment. Don't you forget. If you ever memorize one pathophysiologic equation, let it be this one. Oxygen delivery. Oxygen delivery is absolutely essential to life. I go back to the parts of this equation all the time when I'm assessing patients who are really sick to make sure I'm doing everything right, and sometimes it's even helpful in diagnostic situations. Remember, oxygen delivery is basically cardiac output times hemoglobin times oxygen saturation. Cardiac output equals heart rate times stroke volume. And in this case, stroke volume is a factor of the volume or preload and the pump function. When you're resuscitating critically ill patients, you want to maximize oxygen delivery. Make sure that you give your sick patients supplemental oxygen. Make sure you fill the tank. Make sure they have enough volume to get adequate preload which is necessitated for good oxygen delivery. Make sure to optimize hemoglobin. Severely anemic patients cannot carry oxygen. Once you go through those 3 things, then you might need to support the vasculature and ionotropic activity as needed. But never, never, never start vasopressors until the tank is full. Fluid resuscitation is always first. All right, so how would we clear the circulation? Go look at the patient, going through the ABCs. You find a patient who's awake and alert with normal vital, sinus rhythm, good perfusion. You've cleared the ABCs. It's time to go on and think about the medical problem. You can use this assessment of the ABCs in patients who are sick and patients who are not sick. It should be routine. You should consider these components every time you assess an emergency medicine patient. If you approach this in when you approach the critical patients like this, you'll address the ABCs systematically. You'll identify every threat to them. Then you stabilize the ABCs in order. You miss nothing and you move on. You've got a patient you can deal with. There's no reason to be scared. Resuscitation is easy. Memorize the axiom and establish a consistent approach. This is the key to your success. Gain control of the situation and you can do anything. So the first of many times I'll tell you this. I wear this ring. I wear it on my thumb all the time to remind me to harm none. That's my job. It actually comes from a Wiccan axiom, or a Wiccan rule. I'm actually not Wiccan. The Halloween stuff would suggest I am, but I'm really not. But I think this is an awesome rule. The idea behind it is that you can do anything. You can exert your power on anyone as long as you do no harm. Nothing bad will come of it. The corollary to that is for everything every time you use your powers for bad, it'll come back to you threefold. I don't want anything to come back to me threefold, so I try my best to harm none of my patients. And I have this reminder on my thumb all the time that that's my job. All right, be careful out there. Move on to Module 2.